Dr. Elliott Haut will join us again, this time to talk about implementation science and how we can use it to approach outcome measurement.
Great. Okay. Thanks again for the invitation from me to talk. Actually, a different clicker. We're going to talk a little bit about implementation science approaches and outcomes measurement. Feel free to tweet. Disclosure, part of this work is funded by PCORI, and I think it absolutely makes sense because we're funded by them to do implementation, and you'll hear about some of the project plot through that we're working on. So let's talk a little bit about the basics of implementation science. There's a few different papers I'm going to reference. They're short, quick, easy reads. This one is in a series in JAMA Surgery, a practical guide to a bunch of different types of research. We wrote the one about implementation science. And, you know, I like to quote, it's from our paper. Implementation science is the study of methods and strategies to promote the adoption and integration of proven clinical treatments, practices, organizational management, et cetera, to improve health. So that's the goal. I know Deb Stein had to leave, but she asked this important question. She tasked the group today with this afternoon, some of these things. Let's figure out, know the data on what we should do. How do we do it? And maybe an implementation science framework is a way to go. These are some of the, the box of topics that we talked about in implementation science. I'm not going to read each one, but you've got to design it well. You have to implement it well. It's implementation science, and then ways to study it and the outcomes. And for people who have a PhD in epidemiology, you know who that is in the room, the outcomes are very different, right? So we're going to talk about those look like. They're not mortality. They are not morbidity. They are not DVT. They're not, these other outcomes that we think of when we do typical health services research. There's another paper on the topic, also in JAMA Surgery. This is in a series of research papers that came out from the Surgical Outcomes Club in collaboration with JAMA Surgery. And this talks about same idea, promote the uptake of evidence-based interventions into clinical practice. How do we get practice to change based on the information? So put this up here with a bunch of different pictures. Here's this typical word cloud and, some flow diagrams. And, there are entire conferences, journals, books, education, all these other things about knowledge translation and implementation science. There are people that get whole entire PhDs on implementation science alone. It is a fully developed field of research. Okay? Here's one example of a framework. And the key, I think, to implementation science is don't just wing it. Use one of these well-accepted frameworks for your projects regarding implementation science. So here's one that I really like. Part of the reason I really like it is, my PhD mentor, Peter Pronovost, wrote it, but that's not the only reason. It is a well-accepted, high-end approach to translating evidence into practice. Here's a very specific model, and we're talking about VTE today, but you could take this home and use this model for anything you want to do to translate evidence into practice. Hey, we have a guideline on whatever topic. How do you make that actually happen at your trauma center or your hospital or your clinic or your elective practice or your ED or wherever? How do you make it happen? So this is a nice, easy, quick citation. I'm going to go through what it looks like. It keeps getting cited again and again and again in super high impact journals as well as in grant proposals. And the grant reviewers that are looking at implementation science really want to see your framework. This is one of them I'll show you, and then I have another one as well. So I'm going to run through what this looks like. I know you can't read it on this slide, so I broke it out. So the first is you need to summarize the evidence, right? We've done that a little bit already here. There are guidelines that do it, whether it's an EAST guideline or a Western trauma or the COT or a neurosurgery, et cetera, et cetera. You have to summarize the evidence. You have to know what the thing is that you want to do. Then you're going to say, okay, here's the thing. What are the barriers? Why can't we do this? Why aren't we doing this? What can we do better to do that? Sometimes it's going out and, like I talked about yesterday, you're going to talk to nurses. Why are they not giving it? And you read all these quotes and you're like, oh my God, someone at the meeting asked me for the paper. I resent them the paper and I'd forgotten. It has all these quotes in there that nurses tell you. And you're like, wow, you need to help identify those local barriers. So that's one of the steps. And then you're going to need to measure something. Okay? Some things we're already measuring, whether you're measuring it in TQIP, whether you're measuring it on your hospital thing, whether you have some dashboard, whatever it is, you're going to have to measure something that's a process and or an outcome and know what it looks like in the beginning, because then part of it's going to be, did you improve? You need to know what your baseline is before you do something. So those are the first 3 steps of TRIP. And then here's the 4th step. The 4th step is this multi approach to engaging. You got to get at the front line. You got to talk to, whether it's nurses, residents, whoever it's going to be. You have to educate them on, here's the protocol, here's the guideline, here's the thing we're going to do, here's the order set in Epic, here's the whatever. And then you're going to actually have to execute it. There's a toolkit, and it's targeted at standardization, so that you can make it the same way every time. And then there's reevaluate or evaluate is let's look at the data. And you might want to do an intervention and you look at the data every month and see how you're doing, and then you're going to re-engage, et cetera, and that's the circular pattern. Okay? So this is the ensure everybody gets the intervention and then study it. So it's a great framework for a lot of stuff we do in process improvement, PI, whether, like I said, it's on trauma or surgery or wherever it's going to be. That's one framework to look at for how do you do this. The other thing, there's another framework, and for implementation science experts, this is the gold standard. And it's called CFR, the Consolidated Framework for Implementation Research, and it provides a menu. So you can go to the CFR website, and I have the website link up here, and go find out tons of information about all different aspects of implementation science. The buzzwords they use are barriers and facilitators. So they make sense. Barriers are things you have to overcome. Facilitators are things that make your project go easier, et cetera. So these barriers and facilitators, and I'll use that terminology later as I give some specific examples. So you can't read it, and that's okay. You just understand that it's broken down into these multiple domains, inner setting, outer setting. Where is it? Is it from the outside? Is it from the inside? Is it local on each place, et cetera, et cetera? And then you can pick and choose. You don't have to do every single piece, but you can pick and choose which are the important things that might apply for your project that you're doing. There's another nice dissemination and implementation, and actually de-implementation. If you think about it, implementation is, why aren't we doing X for patients? Because it's the right thing to do. De-implementation is the opposite. We keep doing this thing even though we probably shouldn't. De-implementation doesn't get talked about enough. We made sure to add it into this project. This paper, Vanessa Haut is the lead author. This came out of a conference put on by the College of Surgeons about research methodology, College of Surgeons in collaboration with Center, and we wrote a series of papers. This one was the methodology of dissemination implementation science. It's great. Obviously, Vanessa did an amazing job, and this paper really talks about it with a trauma lens. Anybody's going to tweet this, can you just tag the journal? That'd be great. I'll tell Dr. Fabian. Got a picture? Okay. So implementation science outcomes. I know it's a little hard to read, and I'm now the person squinting and trying to read my own slide. But it's this idea of what are the measures? How do you measure implementation? Like I said, you're not measuring how many patients had a DVT, how many had a surgical site infection, how many had a whatever. You're measuring things like acceptability. When I go to a place and say, hey, will you be willing to do this? The nurses say, sure, that sounds great, I like it. Or no, that sucks, I'm not going to. Or adoption, you can measure how many people did this thing. Appropriateness, like does it fit? Like this thing was studied here, but does it fit in my trauma center because it's a level 2 instead of a level 1 or a level 3 or these other types of questions. Cost. Some people say cost you have to include. The Corey doesn't allow looking at cost. But at some point, someone cares about where does this money come from. Feasibility. Can you actually do it? And then I personally think And we talked about this the other day, and the answer was whack-a-mole of how do you sustain? You do this intervention, and you have all this time and energy and money and focus and all this stuff, and then what happens when you got to pivot and do something else, right? And the answer is, how do you sustain these things? So these are some general ideas of what implementation science outcomes might look like. Very, very different than typical health services research that we talk about. So that was the, tell me about implementation science in a 5 or 10 minute nutshell. So then, okay, now what does this have to do with VTE? I'm going to bring it back home and hopefully answer some of those questions with some real world examples. So we heard this yesterday. You know, we push to make the orders. We get doctors to make write the order for VTE prophylaxis, but does prescription equal administration? We already asked that question. We talked about you need all these steps along the way. Missed doses matter. We're not the only ones writing about that. It happens in trauma, general surgery, elective surgery. There's a colorectal project as well. Okay? You heard about if you educate nurses, they improve their practice for giving VTE prophylaxis to patients. And then you heard about the VTE bundle, right? So you heard about this paper education, video, et cetera. So you've heard about that. So now that was, the last few pieces were built on our first initial PCORI project. Since then, we now have further funding from PCORI for dissemination and implementation. So the first piece we did was locally at our hospital, as well as one of our community hospitals in our system. I'm not going to talk that much about it because I want to talk to this trauma audience about the trauma side of things. And as a reminder, I just want to say thanks to Center. This funding from PCORI went to Center with subcontracts out to me at Hopkins and my group, as well as 10 trauma centers. Some of the people are in the room here. This is affectionately known as CLOT 3, following up on Peggy Knutson's CLOT 1 and 2 we heard about yesterday. Okay, so we got this award. This came to us as the CLOT group, funded, like I said, through PCORI to Center. So it's this collaboration between Johns Hopkins, Center. Thanks, Pam, for making our cool logo for CLOT 3. If you want more information, if you go to bit.ly blood clots, you can get a bunch of this information. Okay, so we had the stakeholder organizations that are heavily involved. You've heard about those as well. So what does this have to do with implementation science? I'm getting there. Okay, so we talked about those buzzwords of facilitators and barriers. So what are they? So here's some specific examples. So we're now taking this stuff that we did at one specific hospital in one specific way. The initial project was a research project on 4 floors, and now we're going to spread that out. So what are the facilitators? The facilitators are engaged leaders at each site. So we have a conference call that Lizette helps us run from Center every month, and we have people on that call from these 10 trauma centers across the country, right? So Todd is on the call, David Spain is on the call, there's other people that are in the room and virtually that are on the call, and they care about it. They're interested in the project, they have skin in the game, they're getting paid to their center to do this, they're engaged. They want to see this happen, they want to see it work. That engagement has been absolutely critical. I can't make change on the trauma floor in San Diego. They don't care about me, right? They care about Todd. That engaged local leader makes a huge difference. Multidisciplinary teams, it's not just the trauma surgeons. So if you're on one of these calls, it's the trauma surgeon leader and the trauma program manager, usually a nurse, and the nurse manager for the floor where they're doing this intervention, and their informatics person who's going to do it, and their research person who's going to do it. We've heard about multidisciplinary teams multiple times. This is a group here today, multidisciplinary. Without that, you can't make change. Just like I said, nobody in San Diego wants to listen to me. The nurses really don't want to listen to Todd. I'm sorry. It's true, and we know this, and it's just the way we have to accept it. The nurses really want to learn from other nurses. So what do I bring to the table? I have a nurse. She's a dedicated ICU nurse. She's worked at Hopkins Hospital for 25 years, experienced ICU nurse, and when she walks around the hospital, people know who she is, and she's the VTE nurse and is great at doing these educations, and nurses want to hear about that at other places. The other facilitator we have is the standardized nurse education. So I showed you the data from that intervention, and I showed you where you can go to the Armstrong Institute and send your nurses to go watch this education, do this online education module, it's standardized. So now we've got all the nurses at all these sites doing the same exact education. That's a facilitator to this project. Instead of saying, hey, Todd, why don't you just go teach your nurses about VTE is important, and you might tell them different stuff than I might tell them. You might believe in the myth about ambulation, and then you're going to perpetuate that. We have the standardized education. It's a great facilitator for implementation. So here exactly is where you can go and do that. The patient education materials are all free. They're funded by PCORI. They're freely available. They're free on YouTube. You can download all the PDFs, et cetera. The nurse education, because of the way it's hosted, there is a small fee associated with it. So if you're going to want to do this, we got to figure out how to get that paid for. We obviously have this paid for by PCORI now for the project. So here's an implementation science outcomes table. I have de-identified it, but imagine, if you will, that when we look at this on our call, these are identified. A is Todd, and B is so-and-so, and C is so-and-so, and you can see which groups are doing well. So the way that this is set up, we've got these 10 sites. They're just have these letters. They are how many nurses have gone online and completed the online education, and what's their target. As you might imagine, each site has different targets. Some sites have 1 floor, some have 2 or 3 floors, some have 50 nurses, some have 250 nurses, et cetera, and where's their percentage completion? We're targeting about 80%. We think that's probably good enough. Nothing's ever going to get to 100%. And you can see right now we're 6 sites that are over that 80%. We've got 2 or 3 that are pressing it. They're almost there. And then, as you might imagine, there's a little bell curve, and there's a few that are laggards. So it's nice to be able to say to sites D and E, like, hey, what can we do to help you? Hey, and I'll pick on Todd again because I like Todd. Todd's site was the first one to hit 80%. And literally I asked Todd on these calls, like, hey, could you talk to us about how you made this happen? And it's great for, a trauma surgeon at such and such place to hear from a trauma surgeon here, like, I got it to 80%, here's how I did it. When I'm on the rounds on that floor, I'll be like, hey, have you done the online education? What do you think of it? Oh, I didn't do it yet. Oh, well, when you get a chance, could you please do it? Like, those kinds of things make a difference. The pure learning from the good end towards the bad end is really helpful. That's the idea behind TQIP. We're using the same thing. And so this is a very typical implementation science type table of data. What are some other facilitators we have? Validated patient education materials. So, there's data behind how we did it. We worked with the national patient organizations. We had patients on the paper about what did they want to hear. The materials are out there. They are standard. You don't have to say, give them some patient education, go talk to them. We give them, here's the paper. It's valid. It's here. Oh, you want it in a different language? Great. We have it professionally translated. Here's the video. Go and watch it. And then we have a toolkit for how do you roll this out. Somebody asked me yesterday, well, how did you actually show them the video? And I'll tell it right now. So in the original study, the way we did this was a nurse got an alert. Doreen literally did most of the time, would go into the patient's room, hand them the piece of paper, and would say, here's an iPad. We bought iPads, and they literally handed it to the patient. Click, watch this video. That's how we did it. So now how do we do that in the real world? Well, there's a few different options. I'm going to show you a link to a lot of patients or their families have their smartphone in their hospital, right? So you can give them the link. Here's the link directly to the video, and you can watch it that way. And the paper, here's the QR code, watch the video. You can embed it into your electronic medical record. So for places that use Epic, there's Epic MyChart Bedside. Patients are in there all the time, right? So they are looking at their labs, looking at their results. They're doing all these things. We have iPads that we hand to patients so they can do Epic MyChart Bedside. You can embed this video or the video link directly in there. That's a way. In the meantime, before we had that, we actually put it on our hospital TV system. So a lot of places have like an on-demand thing for patient education, et cetera. We put it in there. You could click through and you can watch the video. There's different options for that. But the standardized, not just the materials, but how are you going to get it to patients? That's the implementation. It might be a little bit different at each place. So we've got some toolkit materials. So what does that include? We've got standardized videos. So we have a video of me talking about the project, and that can go to anybody. We have a video of Doreen, our nurse educator, bringing the real nurse perspective, talking to nurses on the floor of, hey, watch this 8-minute video. It'll tell you all about this really cool project. And I'm a nurse, and I'm going to tell you how you're going to do this thing. Okay, great. We have these posters. Each place it talks about, you put it up wherever you're going to put it on that floor. Here's what's going to happen with this project. Here's some ideas behind it, et cetera, et cetera. Standardized materials. The bottom two things over there on the left are, it's a little badge card. You all seen them, the little plastic card, you put it behind your badge. One side is, how do you talk to patients about this topic? And it's bulleted, like, ideas, phrases, wording of how do you do this. You standardize the communication. It's a great communication tool. And then the other side has more information about policies, what to do, et cetera, et cetera. Here's a blow up of the card where, you know, it's a little postcard, and you can hand it out to a patient. Hey, you know, we're doing this thing. Here's what you want to know about your blood clot information. And you can scan either one of those QR codes. One goes directly to YouTube to watch the patient education video, and one goes directly to the webpage that has the patient handout, and they can pick to read it in whatever language that they want. The implementation materials, how do you get it to patients? Multiple different ways. Okay, so those are some of the facilitators. Those are some of the things that are going well. So if I stop right now, you'd be like, great, your project's awesome. Like, you're all done, right? So there actually are a few barriers that we're working to overcome. There's this thing called COVID. I don't know if you guys have heard of it. It turned a little bit into a competing priority. I'm sure you all had the same thing of, we can't do X because we're focusing everything on COVID. Totally makes sense. Nurses burned out, doctors burned out, everybody's burned out. You can't do extra stuff. COVID is a real thing. You know, I happen to pick 3 papers. There's a million papers out there about how COVID has affected lots of stuff. So we have a lot of things that were problematic related to patient safety during COVID because COVID sucked up all the resources. All our QI nurses got pulled into the clinical mix, and we couldn't do as much QI work as we wanted, right? We're not the only ones, right? That happened at all the centers. We heard a lot from our 10 centers. Epic won't let us do this because, you know, we're focused on COVID stuff, this and that. The nurses really, they're not doing any new things because of COVID. Like, it is a real thing. And then, if you haven't read this, you know, the effective trauma care due to the pandemic, we wrote it really early on, and it talks about many different things, one of which is QI, education, et cetera. So COVID is a real thing. There are other barriers, even without COVID, variation in IRB approvals. So I've been talking to some people, this is not a randomized trial where you have the same exact protocol at every single hospital, where your IRB will rely on a central IRB, et cetera. This is quality improvement in implementation science. You still need the IRB to approve looking at patient data. You're looking at Mrs. Smith did or didn't get such and such and has all her information. You need an IRB to approve that. But the question is, what does that approval look like? So I'll tell you, at the 10 centers, some are like, oh yeah, that's research, totally. This is the research column, and our IRB is going to approve it as research and put it in as a research protocol and whatever. Other centers are like, well, it's not really research, so it's quality improvement because you're just doing a thing and it's quality improvement, so put it in as a quality improvement protocol. And then there's centers where, like, you put it in as research, they're like, no, it's quality, so you have to switch it. Or it's quality and no, it's research. So how long does it take to get your IRB approval for these types of things? I will tell you, it's a little bit of variation. Some places got it in 3 days. Michelle knows this, right? And some places got it in 9 months, okay? Because they can't figure out what to do with it. They don't know what to do. Are the nurses, I mean, we had arguments of, are the nurses subjects? What do you think? People, like, most of us said, no, the nurses aren't subjects. The nurses are doing their job. They're going to be assigned to things through their job. Well, are you assigning it? Are you optional? Or is it, like, there's all these questions that are real questions. So the IRB and the research hurdles are real. And then there's the data use agreement. And anyone who's done a data use agreement back and forth with the lawyers, that takes a little while too. That's one of the pieces. Informatics barriers. Interoperability. Oh my gosh, we talk about it all the time of like, oh, we should have interoperability, and then it's really, really, really hard. Okay? Especially when you're trying to build these electronic alerts. At 9 of our sites are Epic, 1 is Cerner. When you're trying to build these alerts, and they're like, well, this is how we do our alerts, and this is how we do our alerts, and well, this hospital has a phone, but this hospital has a pager, and this hospital is going to be a pop-up, and like, you can't make it the same exact way. It's not a research protocol. All these different options. Hospitals' policies and culture. I mean, policy and culture is different everywhere. Different approaches, you know, whether it's policies or just the culture of we hold or we don't hold. The discussion of what should be held for as an offshoot of this CLOT 3, we have a Delphi project right now working on variation in holding practices. Many of you have gotten that survey. We've got about 175 people, trauma surgeons and non-trauma surgeons. When do we hold it? When don't we? To try to get a feel about these differences. Variation in medication formularies. Oh, we have this drug, we have that drug, et cetera. All these diverse workflows. So there are real barriers. I pulled out a few slides I'd given from a different meeting a few meetings ago about this thing, and just some last few ideas. Be ready to change parts of your intervention. You don't want to change the whole thing, but this addresses issues of, hey, if it's not acceptable, you might have to modify it to be more acceptable. If you know your adoption rate is low, you might have to modify it to increase your adoption. You know, maybe cost. We had a nurse, she was paid for 100% by PCORI, and she did this intervention. Maybe each hospital doesn't have a full-time nurse to do this. How are you going to do that? You got to change your cost model potentially, because scaling up from a small research study to I want this everywhere, it doesn't work. Step one, hire a nurse. Okay, well, we're done. We can't do that. Fidelity, are they doing it the same way we expect? So be ready to change parts of it. Get it in writing. And for those of you who mentor junior faculty or are going and getting new jobs, you'd probably give this advice. Get it in writing. If you want to, I mean, things like if you want a private office, Dr. Haut will have a private office. Like even things like that. You know, whatever you're going to get it in writing. So we have had to go back and say, hey, you know, we have a letter from your chief medical informatics officer, chief nursing officer, whatever, that you're going to do this. So we really do need you to do what you said you were going to do. Getting paid this money, and you said you're going to do it. So use that, and we've done that locally as well. I had to go back to our chief nursing officer and be like, literally, this is the letter you wrote for PCORI. They're coming and talking to us today about why we're not doing this. I need your support. So use that, get it in writing, and feel free to use that. Be prepared to battle with bureaucracy. I mean, we do this all the time. Even at my place. So, well, which committee approves that? Who's going to approve this? Well, that's this nursing committee. That's this committee. That's that committee. Is it at a health system? Oh, we can't do that. All our EPIC changes are for our health system of 27 hospitals. Or is it at a hospital, functional unit, floor, nurse? Like, what's the level? Who's deciding all these different things? Lots of different pathways, informatics, EHRs, all these other things. The bureaucracy is bang your head against the wall painful. And then sustainability. Sustainability, I think, is the, it's going to be my hardest problem to do. Like, okay, once we get this going, how do you sustain it? Once the funding goes away, once the pressure goes away, once you're whacking a different mole, how do you get this thing to continue on? So I think it's a great question. I don't have a long-term answer for it, but it definitely has to do with implementation. So you already saw these slides. Thanks for everybody, good group, et cetera, more information. That's my talk on implementation. I got about 5 minutes for Q&A. If anybody has anything, whether it's online or here. Go ahead.
Elliott.
Sorry, if you could re-announce your name for the people online who can't see you.
Elliott, this is Peggy Knudsen, and congratulations on all your really hard work on this subject. My question is about IRB. Is there any movement in any of the organizations that you belong to, or anybody in the room, about having central IRB approval for some of these multi-center studies?
So interestingly, and Michelle might help me answer this, and Eileen as well, this is a little bit of NTRAP 3 of how do you do the regulatory stuff for research. So I know there's a project that you guys are working on and I'm not heavily involved with. We are writing a separate IRB project out of this Class 3 of like, these are the barriers we had with IRBs because of the quality, implementation, et cetera, not necessarily the research piece of it. But I think we should push, and if you go back to the NASM report about zero preventable deaths, there's a piece in there about the regulatory hurdles to overcome, some of which are how do we do emergency research, but a lot of which are how do you use a learning healthcare system, actually change practice, et cetera, et cetera. So I think there is a big push and people want to see that change, but it's slow. It is slow to change the federal government. I mean, it's slow enough to change your hospital. You think that's hard. change the federal government is even worse. Michelle, I don't know if you or Eileen or one of you want to talk about, that NTRAP 3 part.
Yeah, so the National Trauma Research Action Plan, which is, I mentioned yesterday, is a DoD-funded project. AIM-3 was focused on those regulatory barriers. So we pulled together very multidisciplinary expert group, which included IRB representatives, representatives from federal agencies that write regulations, and have done some extensive Delphi work with them, sort of identifying these challenges, and then also brainstorming on some potential solutions. So that paper's in the works, and I think that will be a valuable resource, along with a toolkit that we're going to develop for investigators to help them with some of these regulatory issues. I think the field is evolving. I think what you talked about today is really key, and we've done this for a long time through QI. We just haven't studied it, right? I mean, trauma centers are really good at QI, and we do things, and we look at whether we've had an impact, but we've never measured it, and we haven't really gone to looking at the barriers and the facilitators as well as we should. So I think this is a perfect area of research for our field. I think we need more people doing it, and the IRBs need to catch up to what it means to do implementation science, because it's new for them as well.
And there is overlap. Implementation science and QI, it's not here and here, but it's also not 100% overlap. There's some Venn diagram where it overlaps. And, I mentor all the residents on their quality improvement projects for whatever thing, and I tell them, you should publish your QI project. And I give them this paper written by Peter Pronovost and a medical writer I've worked with for a decade, Chris Holzmiller. How do you write a QI manuscript? And it walks them through, how do you do this? And it really is an added piece to your portfolio of, scholarships. If you're going to be a QI person going up for promotion, you should have papers on quality improvement. So I push them really hard to write those things. So a little plug for all of you people that are doing quality improvement things, please write these things up. Journals are really willing to look at them. Michelle.
So on NTRAP Part 3, we were very intentional about involving leaders from single IRBs like Advara and WERB or WCG, as well as DOD's Human Research Protection Office, and their regulatory leaders. We had a breakout where we specifically put that group of folks together and talked with them more specifically about the challenges of doing emergency setting research and asked them for guidance. So we're coming at it from both ends, the researcher end, as well as developing additional guidances or making sure that the trauma researchers are aware of the guidances that are out there, because we found that so much of the information, no surprise, is siloed. And maybe they've done some really good work with emergency medicine in the past 10 years, but it didn't really make it into the trauma journals, so that's another thing that we're identifying and building into our toolkit of resources.
Well, you nicely discussed and showed your experience with this implementation with the nursing team at your center, which obviously through a lot of hard work has been really successful, and you've rolled it out to other centers. The implementation with that group is different than implementation with surgeons or other physicians. And so maybe you can touch on a little bit of any experience you have or strategies that might differ when we're trying to work with some of our physician colleagues related to evidence-based implementation of guidelines and things in our trauma centers.
Sure. So I gave the example yesterday of the feedback to residents about their practice. Some of it is you just don't know what your partners do. You think, there's 10 of us and we kind of all do it the same. So if you don't have data, it's very hard to get feedback. It's very hard to say, Todd, I think you do such and such. That's a little sketchy. As a trauma director, you can't really do that. As opposed to, we have this data for hundreds and hundreds of patient admissions, and where are the residents and how well are you doing? And then when you rank them and you've got 50 residents and, there's residents at the bottom and there's data that shows they are worse than their peers, people really do change their practice. So I've talked to other trauma directors about how do you use that in your PI model, right? And the idea is, well, if you've got a protocol, okay, you have a protocol for intubation meds. What do you use for intubation, right? And you think everyone does it your way, and you wrote some protocol, and we always use whatever, and we don't use such and such, okay? Whatever your protocol is. you can then go back and be like, okay, over the course of the year, AJ, you followed the protocol 12% of the time, and, you know, James Byrne followed it 50% of the time, and I'm the trauma director, and I followed it 100% of the time. Why? Well, part of it is, well, maybe you don't agree with the protocol, and you, as a trauma director, didn't write a good protocol and get buy-in from the beginning. Part of it is, I didn't know there was a protocol. Where did you tell me about it? How do you, is there an app? Is there an online site? Is there a laminated card? Is it posted in the trauma bay? Like, how do I know about the protocol? And then the other thing is, really, I just assumed I was, like, fine with everybody else. Now that I have my data, I'm going to make a more conscious effort to do that. I don't think anybody goes to work. Here you go. Raise your hand. Who goes to work to provide bad care for patients? Right? Who thinks they do a really good job taking care of patients? Everybody should be raising their hands. Right? Nobody is intentionally doing these things. So I think the idea of, you know, where are you and where's a little bit of data, you know, PI, if you could pull the data for those specific things and bring it back, I think the rare person's going to be really arguing with you. They might argue with how to get the data. They might argue with, you know, hey, we talked about this before. I don't agree with that protocol, and here's why, and I write it out, et cetera. But I think you should be able to have that discussion with the group. And, you know, I give a talk on how do you implement best practices at your trauma center, and I give the examples of, okay, great, you've got a protocol, whether you pull a TQIT protocol, an EAST protocol, a Western trauma algorithm, whether you pull it off the shelf and use it at your center, measure how you're doing it and bring the data back to the actual people, because that's how you're going to actually change practice.